Hello, everyone. Thanks once again for joining us for our weekly briefing on preventing and managing COVID-19 in the workplace. This is our 29th consecutive webinar. And for those of you who join us often, you'll be happy to know that despite Dr. Harris's paternity leave, he's taking out time to continue on with this consecutive presentations because we don't want to break our record. So we're happy he can be with us today. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare, and I'm your moderator for today's session. As you know, we record the session and we post it on our YouTube channel every week. Please submit your questions during the presentation using the Q&A function on Zoom. We'll answer as many questions as we can in the time allowed, which is typically about 40 minutes. And we answer all questions, including those we don't answer during the webinar, in writing, and we post those responses on our website every week. I'm going to turn it over now to Dr. Harris. Dr. Harris is an MD, MBA, MPH. He's board certified in occupational medicine, and he's our Chief Innovation Officer. He's also WorkCare's Associate Medical Director for On-Site Clinical Operations and the lead clinician for WorkCare's COVID-19 response. Thanks again for joining us.
Excellent. Thank you, Karen. And thanks, everyone, for joining us once again for another, in this case, very exciting, very informative, and going to be hopefully something that impacts many of your workforce in terms of mental health. And so we'll go ahead and jump into it here. Again, thanks for joining us. We don't take it for granted that you continue to show up in the hundreds here. And we want to make sure we're delivering actionable information to you week after week to ensure that you have the most up-to-date information on how best to protect your workforce. So with that being said, the format for today will follow as usual, our clinical update, followed by some pathology, microbiology, more pathology today. Then we'll do the numbers in terms of where we're at from a COVID standpoint, prevalence and incidence in the US and across the pond as well. And then we'll talk about some preventative strategies, followed by what we're doing at WorkCare to help deliver some tools and services that will, again, benefit your workforce. And today, the focus is all about mental health and wellness and depression. And if we talk about then that as a presenter of COVID and the impact from COVID, can we make the association? Can we say that COVID clinical presentation is depression? And if we look at the impact of COVID, not just from a impact from a individual standpoint of I contracted COVID and now I'm having depressive features, which certainly may be a case, but we're also going to talk about it in context of the pandemic and the overall impact to your workforce as a result of this pandemic, and depression and mental health and well-being being something that is very prominent that we're seeing. And we spoke about this, I think about 2.5 months ago, and we touched on it briefly during that time. We're going to go into more depth here and talk about some of the features of depression, but we want to talk about also some solutions from a organizational standpoint, not just from a individual what can I do standpoint. And so let's add depression and mental health impact to the list of clinical manifestations as a result of COVID, because we know there's a strong causal relationship that's evolving on a daily basis here. And so if we look at then the attention that has been paid to in regards to the mental impact of COVID-19, we see that WHO way back in March came out with guidance and a bit of a cautionary message around understanding the psychosocial considerations in regards to COVID-19 pandemic. And so because of this, we see that individual countries are paying attention to some of the psychosocial considerations, but we need to do more. And even in the US, we know because of the shortage of mental health providers and clinicians, we have a gap in the continuum of care for our workforce because of the drastic increases that we've seen. So let's get into what this looks like. Let's get into what the CDC has commented on in regards to mental health in the workplace in general. We see that the studies have shown that the cost of treating individuals both for mental health as well as their physical conditions can be two to three times greater. Excuse me. So let's rephrase that. So treating people that have mental health disorders for their physical ailments is 2 to 3 times higher in cost than those who don't have mental health underlying conditions. Okay, and so what we glean from this is that it does us all well, not just from a health and well-being standpoint, but from a cost standpoint as well, if we offer in conjunction with our focus on helping the physical ailments of the workforce, also supplementing that with the mental health and wellness pieces of it, and we can provide better care as well as decreased cost to the tune of $37 billion in the US, estimated by studies and the CDC commenting on that as well. And so when we talk about then the effects of the depression of mental health on the workforce, we can see further comments from CDC touching upon job performance and productivity, engagement with one's work, communication with coworkers, and even physical capabilities and daily functions. And I know all of you as health and wellness, as environmental health and safety professionals have encountered those cases in which someone or maybe even two individuals with very similar injuries have a drastically different recovery period and a period of disability prolonged if one of those individuals have some underlying mental health conditions, right? And so that's what we're talking about. That's what we have to get at, because we know mental health illness, it has increased and will continue to increase during this pandemic, very likely. So when we talk about depression interfering with a person's ability to complete a task at work specifically, 20% of the time, right? 20% of the time, cognitive performance is affected by depression. 35% of the time, 20% for completion of physical tasks, 35% for cognitive tasks. 57% of employees who report moderate depression and 40% who report severe depression actually have treatment. And so we know that that gap is there, has been there in regards to mental health treatment in the US. And even if we account for other health risks like smoking and obesity, still mental health trumps in terms of cost those who are treated for other work-related injuries that have smoking and obesity as a comorbidity. So again, we've seen in the workplace a very strong focus on health and wellness from smoking, from obesity, other comorbidities, but we have to strengthen our efforts to focus in on mental health in order to make the impact that we know is potentially there to decrease costs as well as provide increased care and performance for our workforce. So let's get into the pathology of depression, okay? We're gonna spend some time on this. So put your psychology hat on for a minute here. So what is depression? DSM-5 is the diagnostic Bible, if you would, for understanding depression and diagnosing it clinically. And we want to understand that things have shifted since DSM-4, where you used to have some of these symptoms for about 6 months in order to have the criteria met for depression. This is now the symptoms present for a 2-week period for these symptoms, okay? And one of them being depressive mood and the other being loss of interest or pleasure. But let's go down the list here so we all are on the same page. Depressive mood, most of the day, nearly every day, is criteria number 1. Markedly diminished interest, criteria number 2. Significant weight loss, is a consideration as well, followed by slowing down of thought, reduction of physical movement. So again, put that in context, right? You're a manufacturer, you have folks out on the shop floor, they're essential workforce, they're trying to do their best, and they're affected by mental illness, depression in this case. They physically will move differently and less effectively because of that depression. And so we want to make sure, again, we're increasing our focus on this to help the workforce in their productivity. Focus on fatigue and loss of energy nearly every day, feeling of worthlessness and inappropriate guilt, followed by diminished ability to think or concentrate, indecisiveness. Finally, recurrent thoughts of death, recurrent suicidal ideation. I know most of us, when we think about depression, probably jump to criteria number 8, and if that's not there, oh, okay, they're fine, they're doing okay. Again, that's the moderate to severe side of the mental health continuum. And so when we talk about what most people suffer from, it's not that ideation of suicide or things of that nature. It's mostly the other criteria that we want to be screening for, we want to be looking for, and provide tools to help cope with these as they appear. And then finally, the diagnosis of the depression has to have symptoms that are causal from the distress and impairment socially and occupationally, and not other substance abuse and things of that nature. So when we talk about the statistics now relative to COVID-19, there's some interesting data that has been published. I mentioned this briefly as a teaser on our last conversation, our last presentation last week, but we want to dig into this research more fully so that we can understand truly the impact of COVID-19 on the workforce and depression in the US here. So if we look at then the prevalence of depression symptoms in the US, threefold increase is what we've seen compared to the period before COVID-19. And this study coming from Boston University has done a good job of looking at data pre-COVID from what's called NHANES data. It's a survey, a health survey that is done regularly, and then looking at some Bureau of Labor Statistics and census data that collected information on how individuals were coping during COVID-19 recently this year. And so we'll jump back to that study here in a bit, but we want to look up elsewhere to see, is this specific to the US, this phenomena of depression associated with COVID-19? So we want to look at then, in this case, let's look at Canada. Canada Life is published some information, some data on what the impact is as a result of not just COVID-19, but a result of depression in the workplace. And we want to look at this because we obviously have multinational clients that are operating abroad. And we want to give perspective so that we have solutions that are holistic and can flourish in any setting. And so if we look at the data from Canada Life, which is the oldest life insurer in Canada, 43% of employees would like more support from a human resource standpoint for mental health, okay? If we look at what the managers feel, 4 in 5 managers believe it's their job to intervene if an employee is showing signs of depression. 55% of managers reported intervening, but only 1 in 3 felt they had good enough training to properly intervene. 65% of managers said they could do their job more effectively if they had better ways to cope and manage with distressed employees. If we look at other parts of the data, 47% of the working Canadians agree that work is the most stressful part of their day. 38.6% felt they couldn't tell their manager if they were experiencing mental health problems. And then 82% of employees with mental health issues indicated the impact, it does impact their work. And 53% with physical health issues said it impacts their work. So again, we're seeing that mental health impacts to work and productivity trump those of physical ailments. And so again, what solutions do we need to put in place to bolster that gap in terms of mental health care for our workforce? If we look at then going back to the study from Boston University, it looked at a total of 1,441 participants, and that's post and during COVID. And then pre-COVID, the NHANES data included 5,065 participants. And what we saw in this data, in this research, is that men and women both increased in terms of depression symptoms to the tune of, for men, pre-COVID, 6.9% in this particular study. Went up to 21.9%. For women, it was 10.1%, went up to 33.3%. And if we break that down by age, we also see increases dramatically in 18 to 39. It went from 9% to 38.8%. 40 to 59, those age 40 to 59 went from 144 to, or excuse me, 8.5%. To 26.8%. All right, and so when we break this down by race and look at non-Hispanic white, non-Hispanic black, and Hispanic, we're seeing that Hispanic population is hardest hit by depression as a result of COVID, going from 8.4% to 34%. Okay, and the other white and black also being about equally hit, 26.5 and 24.2. So again, it's across the board and continuum of our workforce being impacted by depression because of COVID. And if we look at then some of the stressors from COVID specifically and stratify that in terms of level of stressors, we won't go into the details around how they quantified these stressors. We can talk afterward in that regard, but we want to just make sure that we can see there's low, medium, and high stressors as a result of COVID, and those who had more stressors to the tune of 42.9% experienced depressive changes, right, increases. So we look at this as a strong association of COVID and the impact to increased depressive symptoms. So let's look briefly here now at the mild, moderate, and moderately severe and severe disease when we talk about depressive symptoms. This is from that same study from Boston University, and we can see that all numbers increased in regards to prevalence or impact from COVID-19. So before COVID-19, let's just look at severe, making a significant jump here from 0.7% to 5.1%, right? And so we know that mild has increased and is the largest group there at 16.2 before and 24.6 during COVID. So if we look at this another way in a histogram, we're seeing the difference here more drastically in terms of increases in each level of severity of depressive symptoms. So now let's talk about how we're doing with COVID. Are we gonna see more depression because COVID's getting better or worse? And certainly I know a lot of you have been paying attention to the news, and you're seeing that states are being hit hard, cities are being hit hard continually, and even to the tune of New York now, just yesterday, the mayor saying they're going to impose fines on individuals that are not wearing masks in public because their rates have increased above 3% in terms of transmissions, and that's the highest it's been in quite some time. If you look at it on a rolling 7-day average, it's about 1.8%, but again, just recently they crested 3%. And so $50 is what you're going to get fined if you refuse to wear a mask in New York, let's say on the train or on some type of public transit. And again, this is because we're not controlling transmission, and this is another effort to do so by wearing masks and social distancing. When we talk about the numbers then, where we were 2 months ago, or excuse me, 2 weeks ago, 6.5 million individuals affected, went up to 6.8 million in the US, and then now we're at 7.1 million cases in the US as of today. If we look at then over a 7-day rolling average and looking specifically at the cases, the states where the cases are coming from, we're seeing that shift from 2 weeks ago, deepening in the Midwest there last week, and now shifting on the East Coast, and the Dakotas actually getting a little bit worse as well. And so as we look at cases per 100,000, we're seeing again the deepening of these cases across the board, right? There's very few states that are not seeing increases dramatically in cases. And so it's incumbent on us to, as we double back now to mental health, to understand what are the things we're gonna have to have in place for the long haul to help our workforce stay healthy and productive here. Overall, 2 weeks ago, U.S. compared to the world here, India is still, again, hardest hit now globally by COVID. And the U.S. 2 weeks ago was making a little bit of an increase here. We started to level off, and we're still at that level place as it stands today. When we look at then the number of deaths, again, we saw an upward trend, started to turn downward last week, and we're kind of leveling off at this point in regards to deaths. If we look at this trend, to continue to look at this trend in terms of tests that are positive, percent tests that are positive, we continually have seen an upward trend from 2 weeks ago, leveled off a little bit last week, but definitively still upwardly trending this week. Again, this is why New York is doing what they have to do to get people to wear masks, because we are trending in the wrong direction with regard to percent of positive cases for the testing that we're doing. Now, regarding testing, we're still seeing that decline as of 2 weeks ago, that leveled off last week, but declining again this week. Now, overall, we've done a little bit better in terms of almost cresting the 1 million tests on the 7-day rolling average, daily rolling average, right? So hopefully we'll continue to see better testing opportunities state to state. Hopefully the election won't have any continued negative effects on the impact to those tests being offered here. So when we talk about prevention, then let's talk about what are some of the strategies that have already been pushed out into the general population for the workforce, for our employers. And one of the first places we're going to look is the Interagency Standing Committee, right? The Interagency Standing Committee, if you haven't heard of them, is a group that was established in 1991 by the UN. They're one of the longest standing groups amongst the UN for joint effort. It's about 18 different country UN members that have come together to offer how to respond to emergencies and outbreaks. And in this case, they focused in on the mental health and psychosocial aspects of COVID-19. And they did so pretty early on, back in February, right? But of course, obviously, before things became endemic and a pandemic in the US, abroad, they were already under fire, if you would. So we want to look to this as some guidance on how we can establish preventative methods here to help protect our workforce. And so this is the pyramid that they offered up in this particular group or body of work. And it starts with 4 different layers, right? 4 different layers of intervention for a community-based effort. And we'll double back to this. We won't go too deeply other than knowing that there is a hierarchical approach to how we offer interventions for our workforce. So when we talk about their perspective and even looking at the Red Cross in this example of how to respond and how do we look at disasters on a huge scale, we know that people will have common reactions to abnormal situations, right? And so certainly that is happening here with COVID. But what we want to make sure we're screening for, or triaging, if you would, are those individuals that are not having normal reactions, but are having reactions that cross the litmus, if you would, into the depressive symptoms that impact their ability to function normally, right? And so that is the approach that we're going to continue with in terms of the lens of our interventions here. So referral to get assistance is something that needs to happen, and it needs to happen more broadly because we know people will have anxiety, depression, and post-traumatic stress disorder as a result of major incidents, major pandemics, and these are some of the things that we are prepared to begin screening for in our workforce. If you're not doing so already and relying on EAP alone, we know it has not historically been enough, particularly now that we've seen a threefold increase in depression, to address and to accurately help individuals find the resources that they need to cope. And so going back to that pyramid, depicted another way here, same principles though, higher needs, more training needed for interventions for mental health support, okay? And so these are the layers of helping that we're talking about here. Basic support begins just at no level of training, really. It's just a kind of community effort to stay connected to individuals, and that connection to individuals will help prevent some of those depressive symptoms in a meaningful way. Now, that becomes more difficult as the workforce is working remotely, and we want to be cognizant of that. And that is one of the factors to increase depression per that study, and that Boston study that we presented, Boston University study. The next layer then is assistance to groups, right? Not necessarily group counseling, but just connected to groups that are focused in on supportive needs and care and awareness for psychosocial issues, right? And again, how do you offer this in a meaningful way, particularly for your remote workforce? Some of those solutions could look like, right, a Zoom type social meeting that is specifically focused on connecting your workforce, certain groups of your workforce, in a way that is supportive, right? So it doesn't necessarily mean that people have to show up together in the same place physically, but being intentional about creating those opportunities, not for just focusing in on what are the work tasks that we got to get done, but separate from that in a Zoom setting, offering the supportive group approach to the psychosocial well-being. And then the next layer then is what we call psychosocial first aid or mental health first aid. And that we, again, are starting to become more specialized in our training. And it does require a level of expertise to understand and even triage at that point who has symptoms of depression that need to be referred or need to be addressed clinically, or who are those individuals that will benefit from some of the interventions that are offered at the first two layers of this continuum. The next layer is finally, is counseling, targeted support, right? Where now we're not doing necessarily a one-on-one in every instance, but at least we have a trained counselor that is delivering not just first aid, but early intervention, if you would. And it still stays at the level potentially of self-care at this point, where the individuals are counseling the employees, the clinicians are counseling the employees on those specific tactics that have been shown to be beneficial from a self-care standpoint, right? And then finally, a referral is made when necessary to a mental health specialist that require the most training, right? Certification and even board certification if we're talking a psychiatrist. So these are the layers that are in place, but offer us a strategy on how to approach our workforce in regards to mental health and well-being that escalates the level of intervention appropriately. Now, when we talk about when to refer, right? When people are having severe problems with sleep, strong emotions, obviously talk of suicide, persistent physical symptoms is very important, alcohol and drug abuse, and those behavioral risks that are identified. Now, think about this in context of the remote workforce. Again, we used to be able to see as an employer, as an HR professional, health and environmental health and safety professional, we could see these type of presentations manifest at work when people were physically seeing each other, right? And interacting. But now that we have a significant number of the workforce still working remotely, it's more difficult to ascertain these shifts in individual presentations, right? And so that's why it's becoming ever more important to have a new strategy on how do we assess the workforce for these type of presentations. So if we look to CDC and what they offer up in terms of recommendations for employers as we consider interventions, CDC says, hey, let's make some mental health self-assessment tools available to all employees. And so if you have that in place, great. If you don't, that's step one, right? Where now the workforce, whether on-site or remotely, can access these self-assessment tools. Secondarily, offer free or subsidized clinical screening. And that's what we are interested in providing in terms of helping your workforce quickly identify who needs the next level of care and who can have interventions that are self-care directed, so that focus is paid to that mental health and well-being in a more poignant way than even just the social groupings, if you would. And then the next we want to look at is seminars, hosting a seminar or workshop via Zoom, and in many cases, obviously, where we're actually addressing, talking about, and considering those psychosocial interventions that are self-care driven, right? The mindfulness, the breathing exercises, meditation. And so we can help you at Work Care put these type of workshops together and have one of our clinicians walk your workforce through how do we accomplish these self-care approaches in a meaningful way. Again, we know they're effective. We just have to focus and be intentional about providing access to solutions like this. Then one of the last ones we want to address here is giving employees an opportunity to participate in discussions and issues that affect their job and their stress, right? We know that a locus of control around your work is one of the promulgating factors of increased stress and unhappiness at work, and certainly a risk factor for depression. So being meaningful to allow employees to communicate their thoughts around work and their job stress is going to be ever more important as things continue to be stressful in COVID-19 pandemic era that we're in right now. So in terms of Work Care, what we're up to in regards to helping workforce with strategies that are very familiar and near to us, you all may be familiar with if you have been a client with Work Care. Even if not, I'm sure you've heard of our incident intervention program, where we have employees who are injured, physically injured, call in 24/7, right? And we offer them an intervention that oftentimes to the tune of 70 to 80% self-care, right? And we know that it works well to have individuals that are still remaining at work and providing self-care to get them back physically to 100%. And when appropriate, we get a doc on the phone and we make recommendations that go beyond necessarily what the nurse who is speaking with the employee can recommend. And that also leads to self-care. And then sometimes it also leads to needing to emergently send someone to a facility, or leads to the eventual recovery with that physician intervention, right? And so what we want to do is to leverage our expertise in providing this remote type of intervention from a mental health standpoint, right? And so we want to take the remote worker on site and offer them a screening tool, digital platform, much like we do with COVID-19, that we've been doing with COVID-19 since March, that we've talked about numerously. And that screening tool then allows us to identify individuals. Sorry, the arrows here are kind of poking out of place here, but allows us to identify then those individuals who need a phone triage type interaction. And from that phone triage, where our clinician is evaluating this individual from a mental health and wellness triage standpoint, we can offer them some first aid and self-care, all right? And then when appropriate, make referrals or recommendations for referrals appropriately. And again, the goal is to tackle the majority of individuals that present from impacted, not just COVID-19, but other underlying depressive symptoms, and allow them to identify and gain access to tools that are going to be beneficial for them, resources that are going to be beneficial for them. If we look at and remember our data here, the majority of individuals have mild to moderate depressive symptoms, and that's pre and post COVID-19 or during COVID-19, right? And so those are the individuals that will benefit most from the self-care and first aid recommendations with this modality of intervention. Obviously, those who have moderate, severe, and severe depressive symptoms may require a referral. And that's great that we'll be able to identify more readily and stratify these individuals and get them the appropriate care that's going to help them maintain the productivity that we know these interventions can help individuals maintain. And so that's the goal, folks, to make sure that we have tools in place to rapidly and holistically identify who needs assistance during this period of COVID-19. Again, if we talk about the vaccine, we talk about the other side of COVID, we have been exhaustive in communicating that COVID is not going anywhere for quite some time, if ever. We're going to be in this pandemic mode at least till summer of next year, when if you look at not just the pundits, but also the experts on when vaccines will be distributed, it'll be summer of next year to the general population. So we'll have to have programs in place to help people through this as they are deeply impacted. And what we want to do at WorkCare is double down on our expertise to provide not just physical interventions that help recovery, but also the mental health and well-being interventions that are going to help keep your workforce safe. So with that, I will stop there and share with you my little guy who was born last week. This is Micah Anthony Harris, and we're happy to welcome him to a new member of the WorkCare team. So thank you so much, and we'll open it up to questions.
Thank you, Dr. Harris. You answered the most important question, which was, how's the baby and what gender? I'm really glad you shared the pictures. We only have a couple questions, and I have one related to your topic. Based on your experience in consulting to all types of companies in the U.S. and predominantly dealing with people at the EH&S level, how well equipped do you think the average U.S. employer is right now to deal with recurring mental health issues that are being exacerbated by the pandemic that were existing prior to?
Sure. If the question is how prepared is an employer that had something in place, but because of the increase in demand, how prepared are employers in general? I would say, unfortunately, they're in the same boat as most of the clinical community. We're not prepared, right? We're missing a lot of people, a lot of significant numbers of the workforce, first from just identifying who has depressive symptoms or is affected with mental health because of COVID. And we know that if we look at some of those factors that are most deeply impacting individuals, it is loss of a job, right? It's loss of a loved one from COVID-19. And then there's other factors in terms of impact to the community and house and individuals and the family members, right? So in terms of our true understanding of the impact, we're only estimating based upon subsegments of the literature being presented, but we know that it likely is still underestimating the incidence of depression and mental health impact. And we're unfortunately just don't have the capacity, both in the clinical as well as the employer side, to undertake at this time the number of people affected. And that's why we just frankly need new tools and new approaches, as we're suggesting in terms of screening, triage, and referrals.
Yeah, it seems like a lot of education is needed to even help people recognize their depressive symptoms or symptoms of anxiety to even ask for the help they need. So got a long way to go, but some great suggestions you gave us today. So 2 other questions, and then we'll be done with our session today. Are we at a point yet that if someone is showing symptoms such as a stuffy nose and not sure if it's from allergies or COVID, and they get a negative COVID test, is it okay to let them to come back to work? Or should we still require 2 negative tests or a single test that meets accuracy standards?
Sure. So the official recommendation, WHO and CDC, is still to have that person quarantine or self-isolate. If they are symptomatic, and they have enough symptoms, not from any underlying condition pre-existing, then they should still quarantine for the necessary time. If they have a negative test and they have a consultation with a clinician, and they may fall in the category of individuals that can come back if they're in the essential workforce sooner, provided they can appropriately wear masks and social distance and in the workplace. What we do know is that individuals are officially no longer infectious after 10 days. There's new literature published that's showing it may be 7 days, only 7 days, and you're no longer infectious after contracting COVID-19. So those who are symptomatic, concerning enough for COVID-19, not just from another underlying condition, should still have a period of self-isolation until that 7-day period has passed. 2 negative tests has gone out of favor, right, with regard to CDC, and is not readily recommended in clinical practice because of the lack of availability of testing across the board. So unfortunately, that's still the kind of status we're in until we have either more highly specific tests that can be relied upon no matter where you're tested. And that's the other issue, right? If you go test and we're unsure of the test that was performed because you went down the street to the local clinic or a hospital, then we can't make a clinical call on whether or not the likelihood of you truly being infectious if you're symptomatic. So I know that was a long answer to that question, but it is because we still don't have a definitive clear line on how to get people back only after a day or two if they have a negative test, which symptoms.
Yeah, for a lot of things, there's really no straight answer. We appreciate you going into some depth. One quick question that kind of follows up on the one I just asked. As an EH&S person, is it better to let HR handle interactions that relate to mental health, or is it something EH&S should handle?
We believe EH&S should work with HR, right? But it is definitely in the purview of EH&S to address the mental health and wellness. And that's pretty much what we're trying to promote, right? That EH&S has traditionally been, even ourselves as clinicians, have traditionally been concerned around the physical ailments of workplace exposures. And so as we focus more in the mental health impacts, which in some cases, again, shown can be more dramatic in terms of performance hindrances, we want to empower and educate EH&S professionals to take on that role because we need more resources in regards to attention to this important subject here and the impacts thereof.
Okay, and one last question. This has come up before, and I think the questioner didn't get an answer, a satisfactory answer maybe, or we just didn't address it in writing. It's about PCR tests. Can you clarify the reliability of PCR? What I understand is when the test is copied over 30 times, it is almost always positive, and when it is copied over 40 times, always positive. PCR test primer sequence is found in all human DNA. Because of this, the developer researcher of PCR stated this test should never be used to detect a virus. So it's kind of a comment more than a question, except they're asking for clarification.
Sure. So PCR tests do detect presence of a genetic material of the virus itself, right? And one of the metrics used in PCR is cycles, right? How many cycle counts are necessary in terms of replicating or amplifying that genetic material that may be present before it can be detected by the test itself. Right now, there are just so many different PCR kits out there, primers that are out there, methodologies that are out there, that vary in their sensitivity and specificity. And so there's no blanket answer to how sensitive or how specific or how accurate PCR is across the board. It is a case-by-case, test-by-test, kit-by-kit, methodology-by-methodology approach. And even if two laboratories use the same approach and same kit, they may have different performance metrics in regards to sensitivity and specificity of that test because of either user error or the equipment that they're using, right? So it's a complex question, complex answer. In general, PCR is still regarded as the gold standard for COVID-19 detection. We don't foresee that going aside by CDC or WHO anytime soon. However, we know that there are other approaches such as aptamers that can detect genetic material. We talked about light microscopy, believe it or not, with AI incorporated that can detect presence of virus in a saliva sample in less than 30 seconds. But again, these are emerging technologies and probably won't trump PCR for some time, if ever, at this point in time.
Okay, well, thank you for that answer and for all your answers and expertise. Congratulations on baby Micah. A lot of our regular attendees are really thrilled to see the pictures. Glad we did that. I just want to thank everyone for joining us again, and we'll see you back next week. Be safe. Thanks, Dr. Harris.
Thank you. Thanks, everyone, and stay safe. God bless. Bye-bye.